بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will discuss the fifth part of the imaging of the pediatric chest, and this part will deal with imaging of the mediastinum. And there will be a remaining part which is number 6. I hope it will handle the most difficult subject in this issue, and it will be on the role of imaging in diagnosis of pediatric diffuse lung diseases. Then in the mediastinum, you know that there are the major vessels in the heart, the thymus, the trachea, and the esophagus, mediastinal lymph nodes, and fat. And you may remember that we have discussed the mediastinum in adults. We said that most of the patients with mediastinal masses are usually asymptomatic, and a good percentage of these mediastinal lesions are discovered incidentally, and they are largely on the benign sector. The symptoms include the symptoms of mediastinal space-occupying lesion will include compressive symptoms related to compression of the esophagus, compression of the trachea, compression of the laryngeal nerve, compression of the veins, and the compression of the spinal cord. Then you may also remember that we have handled the mediastinal pathology in three main categories: the anterior mediastinum, which is anterior to the heart, posterior to the sternum; the posterior mediastinum, which is posterior to the heart, anterior to the spine; and the middle mediastinum, which is presented here in green, including the heart, the great vessels, and the mediastinal lymph nodes. Then also, as been stated in the mediastinum of adults, there will be in each mediastinal compartment a cyst, a hernia, and a group of lymph nodes. Then these are the mediastinal cysts in the pediatric age group. In the anterior mediastinum, we have the thymic cyst, we have the cystic hygroma, and the pleuropericardial cyst. In the middle mediastinum, the bronchogenic cyst. In the posterior mediastinum, we have the duplication cyst as well as the neuroenteric cyst. Then cysts in the mediastinum are usually of the benign nature, and they are filled with fluid density, and if you use MRI, they will show fluid signal intensity, low signal in the T1 and high signal in the T2 weighted image. And most of the mediastinal cysts will show the typical benign cyst criteria, including the 3 positive and 4 negative criteria. The 3 positive are clear water content, paper thin wall, sharp, well-defined margin. The 4 negative issues are that there is no enhancement, no solid components, no internal septations, and no calcification. But you remember that we may have some exceptions in the mediastinal cyst, especially as regard the presence of septation and the calcification. Both can be seen in the mediastinal cyst, and they are considered also benign cysts. And the thymic cyst is a congenital lesion, and it may result from the resistance of the thyropharyngeal duct. The cyst will have the typical cyst criteria with clear water content and paper thin wall. However, Some proteinaceous or hemorrhagic contents will increase the density of the cyst and also will change the signal intensity of the thymic cyst. And this is an anterior mediastinal cyst which is located along the left paratracheal area, compressing the trachea and displaying the vascular structures. And the cyst shows typical appearance on ultrasound, being hypoechoic or anechoic, with these cysts usually show some posterior acoustic enhancement. And this is an incidentally found thymic cyst in the anterior mediastinum, seen in the chest X-ray lateral view as an opacity behind the sternum, and by the CT you see the clear water density of the lesion, which is located in an anatomical location of the thymic gland. Then you know that cystic hygroma is one of the cysts frequently encountered in the neck, and this cyst is usually large. It may contain multiple internal septations, and one of the diagnostic issues that should be reported for the cystic hygroma located in the neck is if there is any mediastinal extension. And that's to say, some of the cystic hygromas in the neck may extend into the mediastinum. However, in the mediastinum, you can see a cystic hygroma which do not have a component in the neck. And you see here in the chest X-ray, you see pleural effusion and some opacity in the right lung. But on the CT scan, you see a cystic lesion with clear water density occupying most of the right hemithorax, displacing the heart to the opposite side. And this was proved to be a cystic hygroma. And cystic hygroma, similar to any other cysts anywhere in the body, may be secondary infected and it will turn at that time into an abscess, showing the criteria of an abscess considering the enhancing margin, the internal septations, and so on. Then the pleuropericardial cyst is a cyst which is very rare in children. It is usually related to the pericardium, commonly seen in the anterior cardiophrenic angle, usually present on the right side. And this cyst measures in the measurement is in the range of 5 to 8 centimeter in diameter. It shows typical cyst criteria, but may contain calcium and may contain internal septations. Then if you look carefully here, then you can easily appreciate that this is not a pulmonary lesion. If this is a pulmonary lesion, and you would say, and this is hydatid cyst, which is the most common cyst containing fluid in the lung. But if you look carefully here and you see, number one, the cyst is conforming with the cardiac contour, meaning that this cyst is within the mediastinum, and if it is inside the lung, it will be rounded or oval in shape, but being conforming to the contour of the lung, meaning that this cyst is located in the mediastinum, and so that it has this oblong shape. And if this cyst is big enough, it will compress the lung, resulting in some areas of atelectasis and consolidation. And this is a huge pleuropericardial cyst located in the anterior mediastinum, showing the fluid density and the thin non-enhancing margin, as you can see here. And bronchogenic cyst is usually seen in relation to the tracheal bifurcation, is considered the most common mediastinal cyst, and this cyst is usually asymptomatic, and whenever it is large enough, it will protrude outside the confinement of the mediastinum, either to the right or to the left, but commonly to the right side. And this is the pre-contrast scan showing a cystic lesion at the level of the tracheal bifurcation, and you see the clear water density, no enhancement, no calcium, no internal septations. And this part of the cyst insinuating itself inside the mediastinum is the clue for diagnosis of this lesion to be of mediastinal origin. And this cyst is totally located within the mediastinum, midline in location related to the descending aorta in the inferior vena cava, and this is a bronchogenic cyst. And this is also an example of a bronchogenic cyst in a typical location. The cyst is protruding some way to the right side. It appears at the level of the tracheal bifurcation, and it shows clear water density, as you can see here. And this is another example of the third cyst, which is located in the posterior mediastinum, that is the esophageal duplication cyst. This cyst is usually related to the esophagus, and it may grow up and down in the mediastinum and sometimes be mistaken for the bronchogenic cyst. Simple cyst with clear water content, as you can see here, and this is an example of esophageal duplication cyst. The cyst is posterior to the trachea, and you see this cyst is located in the superior mediastinum, let us say that, but it is intimately related to the region of the esophagus and the prevertebral space. So you should remember that esophageal duplication cyst may occur upward in the mediastinum or a little bit downward in the mediastinum, being intimately related to the course of the esophagus. And this is an esophageal duplication cyst, which is seen here in the chest X-ray and also in the lateral view. The CT scan confirmed the presence of a fluid-containing cystic lesion in the posterior mediastinum related to the site of the esophagus. And if you look carefully here, you may not be able to detect any abnormality in the frontal and lateral chest X-ray, but if you look carefully here and you see the lesion, which may be this one, and this is an esophageal duplication cyst. Then we have finished with cystic lesions in the mediastinum. Now we are discussing the hernia. And in the mediastinum, we have three hernia. The anterior one is known as the hernia of Morgagni. The posterior one is known as the hernia of Bogdalek, and the middle one is known as the hiatus hernia. And whenever you see gas containing shadows within the hemithorax, especially if they contain air fluid levels, and these gas shadows are continuous with the gas shadows in the abdomen, then you know that the diagnosis is most likely a diaphragmatic hernia, which is far common compared to the lesion which may be mistaken for this, which is the cystic adenomatoid malformation of the lung that we have discussed before. Then in the lateral view, you can see that the bowel loops are located in the anterior mediastinum, posterior to the sternum, and this is the hernia of Morgagni. And this another example of a hernia of Morgagni. You see bowel gas contain extending into the abdomen. It is located in retrosternal area, and this is the barium enema confirming that this is part of the colon. Then here you can see in the lateral view that there is there, there are bowel loops herniating into the anterior part of the mediastinum. The air in the bowel is continuous with the air in the bowel under the diaphragm, and this is the hernia of Morgagni. Hiatus hernia may be seen also in the pediatric age group and is usually diagnosed by barium studies where you can see part of the stomach above the diaphragm, or you see the gastroesophageal junction above the diaphragm, and we have discussed in details the types of hiatus hernia in the sector of barium meal concerning the adult population. And this is a hiatus hernia in a child. And you see in the chest X-ray there are some pleural effusions, and you see this gas shadow, which is confirmed to be part of the stomach by barium study, herniating into the lower part of the chest. And diaphragmatic hernia is the most common gas containing shadows in the chest compared to other pathology. And if you see a lesion like this one, and you see multiple air containing shadows within the hemithorax, and these shadows are continuous with the gas shadows in the abdomen, and you are sure that this is a diaphragmatic hernia. And you may give barium, and you see that there are a lot of bowel loops located in the posterior mediastinum, and this is hernia of Bogdalek. Then you have an idea about the mediastinal lymph nodes. We have discussed this nodes in the sector of anatomy, and we may just remind you by the appearance of mediastinal lymph nodes. You know that we have 9 groups of mediastinal nodes, and these are located in the retrosternal area. They are also known as the internal mammary group of lymph nodes, the prevascular area, which are located along the anterior aspect of the arch of the aorta, the retrocaval area, which are located posterior to the superior vena cava, and the aortic window area, the aortic window group. They are located between the ascending and the descending aorta before the appearance of the pulmonary artery, and the carinal group, which are located in relation to the tracheal bifurcation. Anterior group is known as precarinal. Posterior group, if they are present, are known as the retrocarinal nodes. And lower down between the major bronchi, you got to the subcarinal lymph nodes, and more lower down you can see the hilar group of lymph nodes, and also you can see the zygoesophageal group of lymph nodes related to the esophagus and the azygos vein. And finally, you can see the circumcardiac group of lymph nodes, which are a group usually surrounding the cardiac shadow. And if you remember, we have said that this group of lymph nodes is usually pathognomonic for non-Hodgkin lymphoma, whether you are dealing with a pediatric patient or an adult patient, according to the literature. Then mediastinal lymphadenopathy in children has many etiologies, and these include lymphoma, leukemia, TB, histoplasma, sarcoid, cystic fibrosis, infectious mononucleosis, histiocytosis, Castleman disease, metastatic neoplasms, especially in cases of neuroblastoma in young child, and testicular carcinoma in the teenagers. Then lymphoma is considered one of the most common malignancies in children and adolescents. It accounts for about 13% of newly diagnosed malignancies in this group of patients. The most common mediastinal neoplasm in children is the lymphoma. Non-Hodgkin lymphoma represents about 60%, while Hodgkin disease represents about 40%, and the thymus may be prone to be infiltrated by lymphoma. So that whenever we are discussing thymic masses, we may consider the possibility of primary thymic tumors and also the possibility of thymic lymphoma. Then you see here a big anterior mediastinal soft tissue mass compressing the mediastinal vessels, and it appeared in the brain X-ray as widening of the mediastinum. And you see also the presence of pleural effusion. And if you look carefully, and you can see that the effusion margin is thickened and enhanced, and this may raise the possibility that lymphoma has also involved the pleura, and explains why, explains the cause of the presence of pleural effusion. And in the plain film, you see broadening of the mediastinal borders, and you see lobulation of the mediastinal margin, and in the lateral view, you can see that big, uh, relatively ill-defined soft tissue mass obliterating or occupying the retrosternal area. And by CT, you are able to see the mass which is present in the retrosternal area, compressing or relatively compressing the pulmonary and the aorta, as you can see here. In this example, there is a broadening of the mediastinal shadow. And you see this lobulated margin of the left border and also of the right border. In the lateral view, there is a big soft tissue opacity which is located in the retrosternal area. In this example, you see bossy masses protruding on either side of the mediastinal borders. In the lateral view, the masses or the shadows are located anteriorly, and by CT, you see a big soft tissue homogeneously enhanced mass in the retrosternal area that was diagnosed to be a T-cell lymphoblastic lymphoma. And this is an example of non-Hodgkin lymphoma involving the mediastinal lymph nodes, the prevascular group, the retrocaval group, the subcarinal group, and the affected nodes are bulky, they are homogeneously enhanced, they do not contain calcium, and do not show areas of breakdown. These are the criteria of lymphoma lymph nodes. Non-Hodgkin lymphoma is usually suspected if you see involvement of the circumcardiac group of lymph nodes, and here you see the circumcardiac as well as the posterior mediastinal group of lymph nodes are enlarged, homogeneously enhanced, with no internal areas of breakdown or matrix calcification. Frequently, with this group of lymph nodes, you may see some pericardial effusion. Posterior group of lymph nodes, especially the zygoesophageal group and the subcarinal group, may be involved also by lymphoma, and this is an example of Burkitt's lymphoma, a huge homogeneously enhanced mass in the retrocardiac area, and it is seen here extending along the left-sided pleura and may involve also the right-sided pleura. Then whenever you see that the nodes are necrotic, they contain central areas of breakdown with marginal enhancement, and you know that these nodes are usually of inflammatory etiology, especially the TB. This is tuberculous lymph nodes in the mediastinum, retrosternal group, prevascular group, retrocaval group, and this is the superior vena cava, which is markedly compressed, and there are bilateral pleural effusion. And you remember that TB primary complex is the combination of a pulmonary pathology or pulmonary lesion and the mediastinal lymph nodes that are necrotic and may sometimes contain calcium. And this is one of the common appearances of TB mediastinal lymphadenopathy, where you can see multiple nodes that show central areas of necrosis and marginal enhancement. And many times you can see calcium inside the affected nodes. This patient is proved to have TB, and the CT scan showed multiple small centrally necrotic lymph nodes in the mediastinum, together with diffuse pericardial thickening and enhancement with some pericardial fluid. And this is TB lymphadenopathy and also TB pericarditis. Another example of tuberculous lymphadenopathy in the subcarinal group, you see some of the lymph nodes that are centrally necrotic and marginally enhanced. And we came to the mediastinal masses when we have the anterior mediastinum, where you can see thymic lesions and germ cell tumors. The middle mediastinum is usually presented here by the presence of lymph nodes and the cysts we have discussed before. Then the posterior mediastinum, you got neurogenic tumors, non-neurogenic tumors, and extramedullary hematopoiesis. And you know that each mediastinum, the anterior, middle, and posterior, should have cyst, hernia, and lymph nodes. Then, beside these lesions, you may have a specific other lesions for each mediastinum. In the anterior mediastinum, you have the thymic lesions, which include the normally prominent thymus, ectopic thymus, thymic hyperplasia, thymoma, and thymic lymphoma, as well as the germ cell tumors. Posteriorly, very commonly you see the neurogenic tumors, including the neuroblastoma, ganglioneuroblastoma, and the ganglioneuroma. Sometimes you see non-neurogenic tumors and also the extramedullary hematopoiesis. The thymus is a ductless gland which is located in the anterior mediastinum, and it usually increases in size starting from birth until the age of 8 months, and according to the literature, it should undergo regression in size after this age. But you should know that in PET scan there is some increased uptake of the tracer in the normal thymus between the age of 2 and 13 years old. And the thymus is uh, uh, considered large or prominent, seen in the chest X-ray up to the age of 5 years. There is a large debates about the normal size of the thymus, the age of regression, and sometimes if you look to the chest X-ray and you see that the thymus is looking normal, having the normal configuration, and you know that this is a normally prominent thymus. Then it decreases in size by the age of the first decade, by the age of 10 years, and it should not be prominent in the second decade. And after the age of 10 years, the thymus should almost totally regressed, except for some minimal prominence you can see. 80% of the prominent thymuses occur in boys, and the thymus can be easily appreciated on the plain X-ray. One of the common appearances is the sale sign, as you can see here. Then this is a frequent finding in the pediatric age. Whenever the patient is below the age of 1 year, and you can see the thymus as prominent like this one, and after this age, and you see the classic appearance of the sale sign. Then this is the regressive appearance of the thymus in relation to age. This is at the age of 3 months. then at 10 years, then at 17 years, and you see minimal tissue in the anterior mediastinum, which represents the remnants of the thymic gland. And thymic pathology generally is rare, concerning the ectopic thymus, hyperplasia, thymoma, thymic lymphoma. And then the thymic pathology occurs in about 80 to 90% of patients with myasthenia gravis. This pathology may be in the form of hyperplasia in most of the cases, thymoma in 10 to 20% of the cases, and thymic atrophy in 10% of the cases. And ectopic thymus is uh, a thymic tissue which is not present in the anterior mediastinum but usually located in the right paratracheal area posterior to the superior vena cava. And the clue for this lesion to be related to the thymus is that its exact similar CT density to the original thymic tissue before contrast, after contrast, and also in MRI in the T1 and T2 and post-gadolinium, the ectopic thymic tissue, which is located in the right paratracheal area posterior to the superior vena cava, should conform with the signal intensity of the original thymus in all pulse sequences. And thymic hyperplasia is considered very rare, and the enlargement of the thymus for the diagnosis of hyperplasia, the thymus should maintain its normal configuration, but it looks more bulky than it should be. Thymic hyperplasia means that there is a more than 50% increase in the volume of the thymus. And in all conditions, CT, MRI, PET scan cannot differentiate the rebound hyperplasia from the true tumor infiltration. As you know that the thymus on PET scan shows normal increased uptake between the age of 3 and 13 years of age. Then there is a gradual decrease if you can see on serial imaging gradual decrease in size, and this in favor of rebound hyperplasia, and this regression reaches the normal situation in about 3 to 6 months. True thymic hyperplasia is associated usually with burns, radiation therapy, or rebound hyperplasia in relation to chemotherapy. Lymphoid hyperplasia, or what is known as autoimmune thymitis, may be seen in cases of myasthenia gravis, rheumatoid arthritis, scleroderma, Graves' disease, and systemic lupus. This patient with breast cancer treated by chemotherapy show some rebound hyperplasia of the thymic gland, and this is not a lymph node, and this is not a metastatic deposit. This is just hyperplasia of the thymus in relation to chemotherapy. And this is thymic lymphoid hyperplasia in a patient with myasthenia gravis. You see the prominence of the thymus, which should not be seen in this age, but you can see a thymic tissue in its exact anatomical location. In this chest X-ray, there is a big mass occupying the left hemithorax, displacing the heart to the opposite side. The CT scan showed a huge mass occupying the left hemithorax, compressing the left lung, and crossing the mediastinal border to the opposite side, and this was proved to be thymic hyperplasia. And histiocytosis of the thymus is rare, and this lesion is usually associated with other manifestations of histiocytosis elsewhere in the body, especially in the lung. Then the thymic masses are included in the differential diagnosis, or the differential diagnosis of thymic masses will include teratoma, thymoma, hyperplasia, HIV-related infection, and confluent lymphadenopathy. As I have mentioned that the thymus may be involved in lymphoma, or the lymph nodes in the anterior mediastinum may form a bulky mass which may be mistaken for a thymic mass. Then thymoma is a rare pathology accounting for about 4% of the pediatric mediastinal neoplasms, and thymomas are found to be associated with autoimmune diseases like myasthenia gravis, diabetes mellitus, autoimmune hepatitis, Hashimoto's thyroiditis, and also with other diseases like pancytopenia, myopathy, systemic lupus, anaplastic anemia, and hypogammaglobulinemia. And in cases of thymic neoplasms or thymoma, you see big mass in the anterior mediastinum conforming to the anatomic location of the thymic gland. It may extend on both sides of the midline if it is large, and may grow like this, and also may extend into the right side of the mediastinum. In this chest X-ray, you see a mass that is looking to be in the left lung, but the CT scan showed that the mass is located in the anterior mediastinum with left-sided bulge encroaching on the left hemithorax. Thymoma may contain calcium, may contain areas of breakdown. And in this chest X-ray, you see a mass which is related to the right mediastinal border. In the lateral view, the mass is projected in the anterior mediastinum. The CT scan showed an anterior mediastinal mass protruding mainly to the right side, and this was proved to be a thymoma. Of course, mediastinal masses are usually diagnosed by CT-guided needle biopsy and or ultrasound-guided needle biopsies, unless there are some of the supportive diagnostic criteria as I will mention. In here, in the chest X-ray, there is broadening of the mediastinal borders. In the lateral view, there is a well-defined soft tissue mass projecting in the anterior mediastinum, and then the CT scan showed the mass at the thymic location, which is projecting on either side of the mediastinum, mainly to the right side, and this was proved to be a thymoma. And here you see a lesion which is related to the aortic contour, but you can easily appreciate the well definition of the aorta. Then this should not be of aortic origin, and the MRI confirmed that the lesion is located within the anterior mediastinal fat along the anterior aspect of the arch of the aorta, and this was a thymoma. Broadening of the mediastinal borders usually suggests the possibility of lymphoma. And here you can see a big mass in the anterior mediastinum encasing the vessels, and this mass is also surrounding the cardiac border. It contains some areas of breakdown, and this was proved to be T-cell lymphoma. This is also a mediastinal lymphoma, a big mass in the anterior mediastinum. The vessels are floating inside the mass, what we call the floating vessel sign, The mass is almost homogeneous apart from some minute areas of breakdown, and this was lymphoma of the anterior mediastinum. You remember that anterior mediastinal lymphoma may originate from the mediastinal lymph nodes or from the thymus. In the chest X-ray, there is a mass on the right side of the mediastinum. In the lateral view, the mass is projected anteriorly behind the sternum, and the MRI, and this is T1, and this is T1 post contrast, and this is T2. The mass is big, is located behind the sternum, and this was proved to be lymphoma infiltrating the thymic gland. Then germ cell tumors are considered the third most common mediastinal neoplasms after lymphoma and the neurogenic tumors. These tumors are easily diagnosed by imaging because of the presence of specific components that are fat and calcium inside the lesion. And teratomas may be of the mature form, which is common, the immature form, and the mixed type. Up to 26% of teratomas contain calcium, and the most important finding for the diagnosis of teratoma is the presence of fat. And there is a big mass here containing calcium, containing fat, which is this dark streaks, and the fluid. Then we have three components: fluid, fat, and calcium. There may be also some soft tissue shadows inside the lesion. And for the diagnosis of teratoma in the mediastinum, teratomas are usually located in the anterior mediastinum. There should be uh, calcium, it should be fat and fluid. But many times you don't see calcium, you see only fat and the fluid, and these are enough for the diagnosis. And also, if you see calcium and fat, this is good for the diagnosis. But if you don't see fat, this will make the diagnosis very difficult, and you will proceed to have a biopsy to confirm the diagnosis. And here you see fat and you see some other soft tissue structures, but you don't see calcium and you don't see fluid. Then the diagnosis is based on the detection of fat within this lesion. And also here you see a big anterior mediastinal mass. These hypodensities are related to the fat content of the lesion, and these hyperdensities are vessels in the mediastinum, but you cannot see actually the presence of fat. If you search very thoroughly, and then there is a 3 millimeter calcium seen within the mass, I am not able to elicit this calcific part of the tumor, but calcium is not an essential finding for the diagnosis of teratoma, but fat is very important for the diagnosis. And here you see the presence of a fat-containing lesion in the anterior mediastinum, foci of calcification within the lesion, then the diagnosis of teratoma is easy. In this chest X-ray, there is a big mass on the left side, and the CT scan showed that the mass contains solid component, fat, which is hypodense, and the foci of calcification. Then the diagnosis of mediastinal teratoma was suggested. The chest X-ray shows a relatively well-defined mass on the left side. The mass is seen anteriorly in the lateral view, and the CT scan showed the fat content of the lesion, some fluid, but there is no calcium. And the fat content is the, the finding which suggests the possibility of mediastinal teratoma. In the chest X-ray, you can see big opacity here, and you see gross areas of calcification within this opacity. The CT scan before and after contrast enhancement showed the three components of teratoma: fluid, fat, and calcium. Also, sometimes you can see a mass which is formed of pure fat in the mediastinum, where with no evidence of fluid, no evidence of calcium, no evidence of other soft tissues, then you may say that this is just a mediastinal lipoma. Posterior mediastinal masses are largely of neurogenic origin, and these represent about 30 to 40% of the mediastinal masses, and 90% of the masses in the posterior mediastinum are of neurogenic origin. In adults, we have three major pathologies in the posterior mediastinum: neurogenic tumors, esophageal pathology, and vertebral pathology. In the pediatric age group, we have neurogenic tumors, non-neurogenic tumors, esophageal and vertebral pathology, as well as extramedullary hematopoiesis. Of course, you know that extramedullary hematopoiesis can be seen also in adult population, but frequently identified in the pediatric age group. When we discussed the diagnosis of pulmonary masses, and we have referred to the issue of neuroblastoma. Actually, the neuroblastoma is a mediastinal mass, but is frequently seen on imaging as a lung mass because of its big size, and most of the posterior mediastinal tumors look like the pulmonary masses. And neuroblastoma represents about 10% of a childhood cancer, and the thorax is considered the second most common site for neuroblastoma after the adrenal gland. Then neuroblastoma is a big mass in the posterior mediastinum, and one of the clues for being a mediastinal pathology is the compression of the lung, meaning that this lesion is outside the lung, compressing the adjacent parenchyma. Calcium is present in neuroblastoma and detected in about 85% of cases by CT. And this neuroblastoma may have an extension inside the spinal canal. This neuroblastoma may mature to a less aggressive form, which is known as the ganglioneuroblastoma, then to a benign form, which is known as the ganglioneuroma. Then these are the neurogenic tumors seen in the pediatric and adult population. Below the age of 3 years, a posterior mediastinal mass is suspected to be a neuroblastoma. Between 3 and 10 years, you consider the possibility of ganglioneuroblastoma. Above the age of 10 years, consider the possibility of the benign form, which is the ganglioneuroma. And in adults, you consider the benign two forms, which are the schwannoma and the neurofibroma. Then you can not distinguish these lesions by imaging, and you should know that the age is not a pathognomonic factor for differentiating between these tumors. Then if you look here, and you will see a mass which is solid with some areas of breakdown, and there is a foci of calcium, which is located in the paravertebral gutter in a child who is 4 years old, and this age is the age, as you remember, of the ganglioneuroblastoma. But I just have mentioned that the age is not a differentiating point between these tumors, and we usually go by needles to have biopsies and to confirm the diagnosis. In here, there is an ill-defined mass on the left side, and this mass is projected posteriorly in the lateral view, and in the MRI showed a big lesion in the posterior mediastinum in either side of the paravertebral gutter with some intraspinal extension. The age of the patient is 10 months old, and this lesion was proved to be neuroblastoma. Staging of the neuroblastoma is easy whenever you consider that stage 1 is a well circumscribed unilateral tumor with no invasion of the surrounding. Stage 2 is a tumor but with local invasion or ipsilateral nodal metastasis. Stage 3, extension of the tumor to the opposite side with metastatic lymphadenopathy. Stage 4, dissemination with metastatic disease anywhere. And here is a big mass, and the mass is solid. It contains calcium. The patient is 2 years old, and you are dealing with neuroblastoma. It should be remembered that a stage 4S is the stage reserved for children under the age of 1 year who have metastatic disease limited to the liver, skin, bone marrow, but not the cortical bone, and this stage has a very good prognosis. Stage 1 tumors are treated by surgical excision. Stage 2 and 3 will undergo surgical excision followed by chemo and radiotherapy. This is another example of neuroblastoma in the posterior part of the superior mediastinum. The ganglioneuroblastoma is some maturation of the neuroblastoma into ganglioneuroblastoma. Here see a mass showing the criteria of neuroblastoma being posteriorly located, containing calcium in the paravertebral gutter. The age of the patient is 4 years, suggestive that this may be a ganglioneuroblastoma, but is not conclusive. Remember, this female patient, 12 years old, having a mass in the posterior mediastinum, as you see in the lateral view, and this is the appearance of the mass in the CT scan, the MRI, axial and coronal images, and by age we may think of ganglioneuroma, and this was proved to be a ganglioneuroma. This female patient, 22 years old, you expect that you are dealing with a schwannoma or neurofibroma. This mass is located posteriorly by the silhouette sign. If you are able to see the cardiac contour, this means that the mass is not adjacent to the heart, and the heart is anteriorly located and the mass is posteriorly located, and this is well appreciated in the lateral view of the chest X-ray, and also well seen in the CT scan, axial and coronal images. And you should remember that schwannomas have the tendency to be cystic or looking like cystic lesions. They have also more lower density and more lower enhancement compared to the neurofibromas. Non-neurogenic tumors in the posterior mediastinum are not diagnosed from imaging. They are usually diagnosed after histopathology, like Ewing sarcoma, germ cell tumors, and rhabdomyosarcoma. And this is a case of primary pleural rhabdomyosarcoma. Here, the patient is 2 years old, and there is a big mass occupying the left hemithorax. The mass do not contain calcium, and this is not a big issue for the diagnosis of neuroblastoma. You should think that this lesion may represent a neuroblastoma. Then you go by biopsy, and this was proved to be a pleural rhabdomyosarcoma. And this is the MRI of the same case, a huge mass occupying the left hemithorax, depressing the diaphragm and shifting the mediastinum. Also, Ewing sarcoma, you know that Ewing sarcoma can occur in the soft tissues, and sometimes Ewing sarcoma can affect the rib and extend into the thorax, but in this case, this is a primary pulmonary Ewing sarcoma. It is indistinguishable from the neuroblastoma except for the age of the patient. The age is relatively higher than the age of neuroblastoma. The mass contains calcium. It is solid, associated with pleural effusion, and by biopsy, it proved to be a primary pulmonary Ewing sarcoma. This is the axial image. It cannot be differentiated from a neuroblastoma or the mature form of the ganglion neuroblastoma, for example. And the extramedullary hematopoiesis is usually occur in the spleen and the liver and also in the lymph nodes, but uh, sometimes you can see this extramedullary hematopoiesis in the posterior mediastinum. It also can occur in the pleura, in the lung, in the GIT, in the breast, in the skin, in the brain, and kidneys. The pathogenesis is unknown, and the causes include the leukemias, uh, polycythemia vera, essential thrombocytosis, myelofibrosis, hemoglobinopathies, sickle cell disease, and thalassemia. The clue for the diagnosis of extramedullary hematopoiesis is the changes in the ribs and the vertebrae. And you know, in cases of bone marrow depression or in cases of uh, decrease in the red blood cells, should be evidences of bone marrow hyperplasia in the form of the expansion of the medullary cavity, especially of the ribs, and the appearance of trabeculations inside the affected vertebrae and the ribs. Then this appearance may be associated with prominent soft tissue masses along the posterior edges of the ribs and may be seen also anteriorly. These represent the sites of extramedullary hematopoiesis. In patients with chronic anemia, there should be an evidence of bone marrow hyperplasia in the form of expansion and trabeculation, both of the ribs and the vertebrae. Then outside the ribs, you can see these soft tissue shadows, which represent the extramedullary hematopoiesis. And in the chest X-ray, there is a well-defined soft tissue mass in the upper part related to the mediastinal border. In the CT scan, you see the trabeculation of the vertebrae, the expansion of the ribs, and then you should suspect that these lesions represent extramedullary hematopoiesis. This chest X-ray, you see multiple masses on both sides of the vertebrae. In the lateral view, the masses are projected posteriorly. Some of the lesions are seen anteriorly. And in the CT scan, you see the evidences of bone marrow hyperplasia with expansion of the rib and bilateral posterior mediastinal soft tissue masses. This patient with thalassemia shows evidence of bone marrow hyperplasia with expansion of the ribs and posterior mediastinal masses representing extramedullary hematopoiesis. Spinal lesions in the pediatric age that may present by mediastinal pathology in most of the cases are related to spinal infections by TB. And if you see vertebral erosions and involvement of the disc with prevertebral collection representing the cold abscess, and this is tuberculous spondylitis. By MRI, you can see the intraspinal component of the lesion and you see the prevertebral abscesses. It is better to assess these lesions by the sagittal images of the MRI or reconstructed CT, or even in the lateral X-ray of the thoracic spine, where you can see erosive changes in the vertebrae and the prevertebral collection representing the cold abscess. And here in the chest or the frontal X-ray of the dorsal spine and the sagittal reconstructed images see multiple vertebral pathologies and this lesion and another one with some involvement of the related discs, calcium, and the paravertebral collection representing the cold abscess. And this is also tuberculous spondylodiscitis with erosive changes in the vertebra, prevertebral collection, and this arrow points to some extension of the inflammatory lesion in the epidural space. Finally, there are some facts to be remembered. The commonest mediastinal masses in children are cysts and lymph nodes. Bronchogenic cyst is considered the most common cystic lesion in the mediastinum of the child. Lymphoma is the most common solid lesion. Neurogenic and germ cell tumors come after lymphoma. Fat, fluid, and calcium, and maybe soft tissues are essential for the diagnosis of teratomas. All thymic lesions are considered rare except involvement of the thymus by lymphoma. Pericardial cyst is a rare developmental or acquired pathology. Thank you very much. Alhamdulillah Rabbil Alameen.